welcome you to this at least third Northeast Ohio Liver Alliance webinar on topics that are of interest to doctors, providers, and patients and caregivers. This particular one happens during an exciting time for primary biliary cholangitis, and we'll focus on this important disease today. The webinar will basically be a 1-hour discussion with expert hepatologists who will speak to us about epidemiology, diagnosis, workup, and treatment, and we will also hear from PBC stakeholders and caregivers about the patient journey and challenges, and some of the challenges with access that are inherent to our healthcare system. We would like to thank our generous supporters, Ipsen, Intercept, and Gilead, who are all in the fray very much so in PBC in 2024 and hopefully for a long time. I would like to bring to your attention the fact that at the very end of this webinar, you will be asked to fill out a survey, which will help us tailor future activities to your needs. And then you will be, if you choose to do so, taken to a breakout room where you can interact with the 3 supporters this evening regarding treatment options that they have available. This is obviously optional. You don't have to do this. It basically will happen within the context of the label for the drugs they have, and would be the equivalent of having a virtual booth is the best way to describe it. I have the honor of being the Neola board president for this term that I'm hopefully concluding in the next year or so before passing the baton to other folks who will help keep this organization vibrant and for many years to come. The Northeast Ohio Liver Alliance, or Neola, as you know, is a not-for-profit that was founded in 2021, and our goals are to educate healthcare professionals and laypersons about liver disease, to advocate for resources, policy change, and public health interventions that impact liver disease in a positive way, and to support research and public health interventions that benefit persons living with liver disease. And if you are anywhere in Northeast Ohio or beyond, chances are you've attended one of our many, many, many activities this year, and hopefully will continue to do so in the future. Our mission statement is to promote liver health through education, advocacy, and research, and to support persons living with liver disease in Northeast Ohio. We have a distinguished panel this evening. Coming all the way from beautiful Utah is Dr. Terry Box. Terry needs very little introduction, but I'll try. He is the medical director of Project Echo, which has pioneered remote treatment for viral hepatitis, you name it, other things, throughout the U.S. He is an assistant dean for community faculty at the University of Utah, and he is associate professor of medicine at the Spencer Fox Eccles School of Medicine at the University of Utah. Dian-Jung Chiang is a staff hepatologist at the Cleveland Clinic Foundation in the Department of Gastroenterology, Hepatology, and Nutrition, who has focused his research and clinical efforts on the treatment of cholestatic liver disease, with PBC being specifically an interest. So we look forward to his contributions in discussing treatment for this disease. And last but not least, Carol Roberts is a very well-known figure in the PBC world. Carol, among other things, is the PBCers organization president. I would venture to say that PBCers is one of the best organized, most active liver disease organizations by far. And that is not paying Carol and the PBCers lip service. That is just a fact. Carol is a PBC patient and a transplant recipient in good health, and we wish her a long and healthy and productive life in advocating for persons with PBC. And she will talk to us about the patient journey, some of the challenges and opportunities that will be facing folks with PBC for many years to come. And I will hand this over to Dr. Box, who will share his screen next. Please remember to complete the survey, and then there will be a breakout session after that.
Okay, thank you, Dr. Gholam. It is indeed a privilege for me to be able to participate in this wonderful program you have established, and I congratulate you and your colleagues on such a wonderful effort. And it is also a pleasure to be on this panel with Dr. Chiang as well as Ms. Roberts. So we are indeed going to talk about primary biliary cirrhosis, and it is important enough, as you see, that last month was PBC Awareness Month. And if I said primary biliary cirrhosis just then, I apologize. That just underscores that I've been doing this for a while before the change of the name to primary biliary cholangitis. I thought we would start with a very high-level overview of PBC, and I would draw your attention first to the illustration on the right-hand side of this slide. I'll point out the normal appearing liver, gallbladder, external biliary tree, and then the little image of the intrahepatic bile duct system in its normal appearance and function. And then later on, in the course of this autoimmune cholestatic disease, destruction of the bile duct, and eventually, in this particular form of biliary disease, these bile ducts don't only become injured, but they disappear. We have so-called ductopenia in this disorder. And that's why this is a cholestatic disease. Cholestasis refers to basically the failure of bile to move, to flow in its normal form. And then when that doesn't happen, we have untoward events which create a cholestatic environment. So this is an immune-mediated, it's an autoimmune disease that is specifically attacking a very small part of the cell of the cholangiocyte, which is the cell of the bile duct epithelium. And as you see up in the background statement, this is primarily a disease of women. Now, this is an older slide, I admit. And in those days, the ratio of men to women was about 10 to 1. That's fallen. We're diagnosing more and more men who, by the way, I will just say now, tend to have a more aggressive course of this disease than most women. Be that as it may, predominantly a disease of women characterized by destruction and ultimate absence of intrahepatic lobular bile ducts. And as a consequence of this immune attack on the biliary tree, there is fallout in the surrounding tissue, which would be the liver itself, the hepatocytes. And as a consequence of the injury and the inflammation that comes with that, the trigger within the liver to produce fibrin and ultimately bands of collagen is started, and over a period of years, ultimately results in large bands of collagen surrounding nodules of liver with a deformity of the liver itself, obstruction to blood flow, et cetera, in its advanced state. Now, you don't start typically with this advanced disease. Fortunately, in today's world, we are discovering this before we get to the point of cirrhosis. And the two most prominent symptoms of a clinical variety are fatigue and pruritus. Fatigue in about 80% of individuals who have PBC, and pruritus at some point in time in about 70%. And both the fatigue and the pruritus can present as a mild, easily tolerated form of fatigue or pruritus, or a very, very pronounced amount of fatigue and pruritus that makes you crazy, profound excoriations and that sort of thing. I would just remind us now, in case I don't get back to it, that there are associated comorbidities with primary biliary cholangitis. And they too, to a large part, are autoimmune diseases such as Sjogren's syndrome, systemic sclerosis, scleroderma, rheumatoid arthritis, and particularly immune-mediated disorders of the thyroid, Hashimoto's thyroiditis, immune thyroiditis that creates a short period of hyperthyroidism followed by hypothyroidism. Thyroid disease, PBC go hand in hand. Also noteworthy is an elevation of lipids, and that's predominantly HDL, which does not, fortunately, carry with it significant cardiovascular morbidity. Now, this is a disease of women, as I've said 2 or 3 times already, and it's a disease primarily when diagnosed in middle-aged or older women. Now, I have had teenage females in my practice with PBC, but that's unusual. But these women in their 40s, 50s, 60s are already at risk for osteopenia and or osteoporosis. And a cholestatic disease is associated with malabsorption of fat-soluble vitamins, including vitamin D, under which circumstance calcium metabolism is further disrupted. So issues with bone health in patients with PBC are critical. Now, when we think about the typical patient with PBC, we're again talking about a middle-aged or older woman. And as we discussed, this is somewhere between 7 times more frequent in women than men. And there is a relatively unique marker in the blood that goes along with the inflammatory disease. And that would be the AMA, anti-mitochondrial antibody. Now, I will just sort of take a moment here to explain to you why this is really unique for this disease. The autoimmune aspect of this disease arises due to an event that we will never define in all likelihood that precipitates the loss of tolerance of a specific enzyme within the biliary system. And that enzyme happens to reside within the inner lining of the mitochondria of the bile duct cell, the cholangiocyte. This is a loss of tolerance for this one protein called phosphodiesterase complex E2. The immune system goes after it. It no longer looks like friend, it looks like foe. The immune system goes after it. And in the process, antibodies to this are formed, which are appropriately called anti-mitochondrial antibody. The key serologic finding in PBC is anti-mitochondrial antibody, an antibody to that mitochondria of the bile duct system. Now, there are other markers that you may need to use if you don't have, in those rare cases, if you don't have anti-mitochondrial antibody, and those would be 2 specific anti-nuclear antibodies, and they are GP210 and SP100. You don't need to remember that specifically. Just remember in those rare cases, 5 to 15% of the time where you don't have an AMA and you're convinced that this is PBC, order the anti-nuclear antibody SP100 and GP210. Also, maybe even further confusing whether or not this is autoimmune hepatitis and not PBC are the presence of anti-smooth muscle antibodies. Typical for PBC as opposed to autoimmune hepatitis is an elevated IgM total versus an elevated IgG total in autoimmune hepatitis. Now, I showed you a destructing bile duct in that first illustration. That is a microscopic finding. That is not findable on an ERCP or an MRCP. The cholangiogram in primary biliary cholangitis is normal. Now, we used to see a lot of liver histology in our PBC patients because we biopsied almost everyone back in the era when I was a medical student, a medical resident, a GI trainee. But we're not doing that so much anymore. We've learned enough about it that we can proceed without liver biopsy, but there are some classic findings with profound lymphocytic infiltration, a historically pertinent florid duct lesion, and things that look like granulomatous disease on liver biopsy of patients with PBC. Unlike its sister disease, primary sclerosing cholangitis, coexisting inflammatory bowel disease is not present. So, how does this happen? How does one go from having a normal situation with everything in the biliary tree being assumed, and appropriately so, to be normal and not worthy of an immune attack, to all of a sudden you develop this autoimmune process? And there almost certainly is a genetic predisposition in people. You'll see in a minute that there are some HLA alleles that are found commonly in these patients as well as their relatives. And then there must be an environmental stimulus, whether that's a bacterial infection, a viral infection, or some toxin within the environment that precipitates this loss of tolerance and the immune response that leads to, bile duct damage. So we're going to go step by step through the development of this, going from what appears to be normal liver in spite of an ongoing process. When we lose tolerance, we develop the antimitochondrial antibody early in this disease. But as things progress over time, we begin to see clinical, biochemical manifestations of liver injury to the biliary tree. Specifically, that would be an elevated alkaline phosphatase. This is associated with cholangitis that may still be more or less microscopic this time. We start to lose bile ducts, developing more and more bile flow stasis, cholestasis. The bilirubin starts to rise later in the disease. And then with overflow of inflammatory processes into the liver, we begin to develop scar tissue, leading to cirrhosis, portal hypertension, and then what is evidence of end-stage liver disease, jaundice, ascites, bleeding varices, hepatic encephalopathy. And if you don't intervene, such as with appropriate therapy or at the end stage liver transplant, then you will have death. Fatigue and pruritus, I remind myself, can never be ignored. It can really diminish the quality of life in these people, and we must do more than we have previously done with better tools, I hope, to improve these aspects and prevent this progression to end-stage liver disease. I'm not going to take the time to walk you through this slide in detail, but I like to show it in order to underscore the fact that this disease starts in a very silent way. And it may be 10, 15 years before we begin to see the elevated alkaline phosphatase, before the patient reports fatigue or reports pruritus, or you might just coincidentally define an elevated alkaline phosphatase in the liver test. All the while this is going on, whether it's silent or in full-blown clinical presentation, the pathologic process of cholestasis is ongoing with increasing bile duct loss, fibrosis, and cirrhosis. And this can proceed within a patient in sort of a continuous format, or can be here and there, flare, calm, flare, calm. So it is important to monitor your patients when they're on therapy for evidence of disease that has maybe been previously responsive, but is no longer under control. Do not forget that there are more than one disease states that cause cholestatic liver disease, and these are just lists of a spectrum of autoimmune liver injuries here on the left, and on the right is a longer differential diagnosis list of things that can look cholestatic and need to be evaluated in the process of your working this patient up in whom you suspect primary biliary cholangitis. So as promised, here is the strategy for making the diagnosis as endorsed by the liver societies both in the US and in Europe. We no longer require liver biopsy to make this diagnosis. Sure, it will need to be used rarely when you don't have the confirmatory findings. But if you have the proper context, that phenotypic situation that we described earlier, with the increased antimitochondrial antibody, alkaline phosphatase increased at least 1.5 times the upper limit of normal, and the AST elevated, perhaps, but not dramatically so, certainly less than 5 times and usually less than 3 times the upper limit of normal, you can make the diagnosis. As you see, the positive predictive value is extraordinarily high, as well as the sensitivity and specificity. This is the way that we make the vast majority of diagnoses of PBC. Before we move on from this section, let's reconsider the antimitochondrial antibody in that 10 or so % of patients where it's not present, but you are just sure this 56-year-old woman has PBC. Don't forget the anti-nuclear antibodies that we've previously discussed. Again, as you see down here, the GP210 and the SP100, but you're going to have to specifically request them because they're not typically reported out in the usual anti-nuclear antibody report. Finally, underscoring again, IgM is elevated in PBC, unlike its counterpart, autoimmune hepatitis, where you have elevated IgG. I'm going to speak to you shortly about pruritus and then turn it over to my colleague, Dr. Chiang, who will take it from there. Pruritus is something about which we don't know nearly enough, but its prevalence in this disease is approximately 70% at some point during the disease for everybody who has it. Is it due to too much bile salt in the blood, endogenous opioids, histamine, et cetera, as you see here? These are the suspected causes of pruritus, the suspected pruritogens. Now, as you will hear from Ms. Roberts, this is going to be worse at night. And it, in this disease, has a peculiar predilection for the soles of the feet and the palms of the hands in many of the patients. It's exacerbated in pregnancy, it's exacerbated with wool, it's exacerbated with heat. These are things you need to remember and help the patients through. Well, what are we going to do with these multiple different forms of pruritogens? Well, we do have some things that may work. First of all, for bile salts, we're going to use the bile salt sequestrants, cholestyramine, cholestevolam, cholestyramine. If it works for you, try it. For me, bile salt sequestrants have almost never worked. Probably I can't get my patients to use them properly. Endogenous opioids, we have naltrexone as an oral approach and naloxone as an intravenous approach. Serotonin insufficiency, increase it with SSRIs. I do not think this pruritus is driven by histamines, but if you want to try antihistamines, you can. We don't have a solution for the imbalance of progesterone and estrogen that has ever been shown to be effective, but typical second-line therapy after the sequestrants is rifampicin, which is a pregnane XR agonist, which turns off a substance called autotaxin, which increases lipofosfatidic acid, which stimulates the itch receptor somewhere in the nervous system. So here is a suggested stepwise approach to itch. You jump in there wherever you want. I typically start personally with rifampin because, as I said, I have not found good luck with the sequestrants. Naltrexone is useful. Sometimes if you're going to use it, it's nice to put them in the hospital for a day and give them IV naloxone in order to get severe pruritus under control. I personally have tried sertraline only rarely without much benefit, and I have had colleagues who have tried PUVA, P-U-V-A, Sorlin ultraviolet light. but I have not done that myself. So I'm going to stop here and turn it over to Dr. Chiang, who's going to continue to educate us. Dr. Chiang?
Thank you so much, Dr. Box, for the wonderful presentation. Let me share my screen here.
Let me get off of mine.
All right, are you guys able to see my slides?
Yes.
Wonderful. Thank you, Dr. Gholam, for the invitation to speak today. It is absolutely an honor to be among the experts on the panel to talk not only from the physician's perspective, but also to talk this from the patient's perspective. So today I will focus on the treatment of PBC. And this is definitely one of the most exciting year for people interested in PBC because we have two new medication that's approved by the FDA to be used in the US now. And this newly approved medication do change the landscape of treatment. We have new second-line treatment options available, and it helps us to move to a goal-directed care. Prior to this year, most patients suffer from the disease, and there are many patients who do not respond to the first-line treatment, and there's very little that we can offer. Not only we may not be able to accomplish biochemical remission, we're also not able to address their symptoms. Specifically, as Dr. Box has mentioned, they suffer from severe pruritus and fatigue. Some of the first-line medication help us prevent cirrhosis and prevent complications, but many patients do not necessarily respond, as I will touch on in a minute. So this is an outline in the development of PBC treatment over the years. As you can see, initially it was called primary biliary cirrhosis. The name changed to primary biliary cholangitis around year 2015. And that's largely because of the effectiveness of the first-line agent that I put on the right here, ursodeoxycholic acid, or URSO as we know it, that was approved by the FDA in 1997. As a result of the medication, many patients who previously suffered from PBC end up with cirrhosis now have the opportunity to prevent the development of cirrhosis. But after that, there is a long paucity where we don't have any approved medication for PBC. There are medication that has been tried in many different clinical trials and studies, but largely failed to demonstrate effectiveness. Partially because it's a rare disease, it's hard to get enough patients. Partially also because the hurdle that now you have to go through to have a new medication approved because your comparison is no longer placebo. Now you're compared this new medication to the first-line agent, ursodeoxycholic acid. That being said, fibrates, as I put down there, fenofibrate and bezafibrate has been shown to be effective in different clinical studies, but they're not approved by the FDA in the US, and we don't have access to bezafibrate here in the US, but we do have access to fenofibrate as a second-line agent here for off-label use. Then the transition moved on to 2016. We have a new medication, obeticholic acid, which is an FXR agonist that was approved to be used both in the US and the European countries. This medication this year, I will discuss some of the newer clinical trial study results. As a result of some of the newer studies, their approval was denied in the EC European Commission, but FDA is still considering it at this point. So it is still available here in the US to be prescribed. And a few months ago, in 2024, two additional medication was approved by the FDA. First one is elafibranor. The second one is seladelpar. Both of these two medications are in a class of PPAR agonists, which is actually the same receptor that fenofibrate and bezafibrate works on. So I will spend most of my time talking about the newer medications today. But to provide some historical context, I think it's important to go back to the original study that proved the benefit of ursodeoxycholic acid. So this is the first randomized control studies looking at ursodeoxycholic acid in PBC patient that was published 30 years ago. They look at patients who are placed on urso versus placebo and monitor them over the course of 2 years. And their primary outcome is whether there's progression of their liver biochemistry, specifically the bilirubin and alk-phos. As you can see on the graph on the left, for people who are on placebo, they're less likely to respond. And if you look at the panels on the right, patients who are placed on urso are more likely to respond, both in their serum bilirubin, their alkaline phosphatase, as well as their cholesterol level. So there are improvement in their biochemistry. And this is the first study that demonstrates to us that this compound, ursodeoxycholic acid, is beneficial in patients with PBC. It can accomplish or achieve at least partial biochemical response. And then a longer-term follow-up study followed. The first study was published in 1994, 3 years later. And this study not only showed the biochemical response, but also showed that there is an improvement in the outcome of liver transplantation-free survival. So as you can see on the right side, the probability for transplantation and the probability of transplantation or death is much reduced in a group that's treated with urso compared to placebo group. So in the earlier studies using urso in a randomized control trial fashion, previous investigators were able to demonstrate that this compound works not only in accomplishing biochemical remission, also improves the outcome by reducing transplant or reducing death related to PBC. So out of those patients that were treated, it is clear over the years we realized up to 40% or 50% of patients do not respond to the first-line treatment. So people have been then looking for a second-line agent that can help the patient who do not respond. And here comes the bezafibrate study. So this study looked at people who are treated with urso but did not respond properly and randomized them to receive bezafibrate or placebo, and then monitor them over 2 years. So similar to the prior study design, 2-year study, randomized control trial, in looking at their biochemical response first. As you can see on the right side, we do see a nice improvement in their alkaline phosphatase, which starts to show its significance 3 months after treatment, and this continues up to 2 years during the trial period. So the study demonstrated that in patients who do not respond to the first-line agents, now there is a second agent, it's a second-line treatment option for them that can accomplish biochemical response. Not only that, longer-term retrospective studies subsequently also demonstrated that this agent can also achieve liver transplant-free survival. This is not done in a randomized control trial fashion, but it's a large retrospective study, 3,908 patients from Japan. 81% of them received urso only, and 19% received both urso and bezafibrate. And exposure to the combination therapy was associated with a significant decrease in all-cause and liver-related mortality for liver transplantation. And again, this is a one of the larger retrospective study that we can use to demonstrate the significance and as well as the effectiveness of bezafibrate in this population. The other fibrate that's available is fenofibrate that's available in the US and can be used off-label. There's no large study to demonstrate its usefulness here in the US. Here I show you a very small study done in a randomized controlled fashion, and that show in a short amount of time there is improvement in alkaline phosphatase, but there's no long-term data to demonstrate its usefulness. There's no long-term liver transplant-free survival that we can gather either. Now, moving on to the second approved medication for primary biliary cholangitis, that's the obeticholic acid. It is a FXR agonist, which received the accelerated approval for primary biliary cholangitis back in 2016. And one of the conditions of approval is to conduct a long-term study that's called a COBALT phase 3B and 4 outcome study, looking at whether this medication has long-term benefit or not. And the endpoint, primary endpoint was death or liver transplant or complications from cirrhosis, including ascites or high MEL score or any decompensation event. If we look at the graph on the right, if we use intention to treat analysis, unfortunately, there's no significant difference when we follow those patients 6 years out. Now, if we look at from a different analysis using external control and as treated analysis, then we can see there appears to be a difference in significant improvement for those patients who are treated. And the caveat here is that it is very difficult to study a rare disease that is chronic and that it takes a long time for you to develop a hard, solid outcome. And therefore, many times, especially in the study, the COBALT study, many patients drop out of the study, and that may explain why that we're not seeing significant improvement in the longer term. But if we're using external control as treated analysis, we can still see signal of improvement. In a similar fashion, again, this is a longer term phase 3 voice trial in PBC. Initially, we see improvement, but those improvements seems to be sustained, or you can say plateaued, even you're looking at 60 months out. So again, for patients who are not responding or not appropriately responding to ursodeoxycholic acid, at least from the POISE study, we seem to see a sustained response from the obeticholic acid. The challenge, though, in this particular population is many patients suffer the side effect from the medication, specifically pruritus that we have been talking about. And as a result, it's not a medication that many patients are able to take long term. Moving on to the 2 new medications that were just approved this year. The first one is elafibranor. As I mentioned, it's a PPAR agonist, similar to the fibrates. And I will show you the recent publication of the phase 3 randomized control studies. Study design is similar to the previous study using inadequate response or intolerance to urso as an inclusion criteria. The initial design is 1 year, but there is a long-term extension up to 6 years. As you can see here, if we look at panel A on the left upper side, patients who are taking elafibranor compared to placebo has a much higher biochemical response. And this is defined by the improvement in their alkaline phosphatase. Not only that, you can also see there are patients who can have normalization of alkaline phosphatase as a result of taking elafibranor. What's also interesting is if you look at the placebo, which are patients who are only taking the first line ursodeoxycholic acid, there's 0% of them that will accomplish normalization of alkaline phosphatase during the study period. But in those who are taking the new second line PPAR agonist, there's an increasing amount of them that will be able to accomplish complete normalization of their alkaline phosphatase. Another very important key endpoint in the study is they not only look at biochemical response, they're also looking at patient-reported outcome. Specifically, is the pruritus. So as mentioned earlier, many of the patients suffer from severe pruritus. And in this study, they look at elafibranor and to see if they can accomplish improvement in their pruritus. So that's in panel C, changing score in their patient-reported each scale. There seem to be improvement in the treatment arm. As you can see, there's a lot of overlap. So at least based on the study here alone, we cannot say that each is significantly improved. You do see improvement biochemically in alkaline phosphatase. And I think it's important for us to now not only have those biochemical markers as an endpoint in clinical study, but also include those patient-reported outcome in this. Moving on to the last but not least new agent, that's the seladelpar. Another PPAR agonist, but it's a PPAR delta specific agonist. Similar inclusion criteria to the previous study and similar composite response rate as well. What's interesting also is in the patients that's treated with seladelpar, up to 25% of them will have complete normalization of their alkaline phosphatase during the study period. If you compare that to patients who are getting placebo, there's 0% of them will accomplish normalization of alkaline phosphatase. What's most interesting to me is if you look at a patient-reported outcome with pruritus, you can see patients who have pruritus more than 4, which is considered severe. You see improvement in their pruritus 3 months out after the treatment, and that response seems to be sustained. And in the overall population, the pruritus response is also demonstrated as well. So at least in this particular study, we can see the new medication not only can accomplish biochemical remission, but also help patients reduce one of the most severe symptoms that affect their quality of life. So putting all this together, I would say we are now at an age where we have more than one agent that can help us accomplish biochemical remission, and hopefully that will lead into histological remission as well as improve patient outcome, including transplant-free survival, but also their quality of life. As we demonstrated in the previous studies, the newer agents seem to be able to at least help some patients improve their quality of life as well as improve their transplant-free survival. And with the newer agent that's available now, normalization of alkaline phosphatase is achievable. And I show here on the right side, this is a longer-term follow-up study looking at patients who have normalization of alkaline phosphatase, that's a solid line on the top, versus those who only accomplish reduction in alkaline phosphatase between 1 to 1.67 upper limit normal, but not yet completely normalized, versus those who have alkaline phosphatase between 1.67 to 3 times upper limit normal. As a result of the treatment, you can see improved transplant-free survival for those who have normalization of alkaline phosphatase. So this is something that would help patient outcome, and it is something that we are now being able to do more than before. So what's the treatment paradigm now? So the current paradigm that we've been using for many, many years is we have one agent that's approved, that's the ursodeoxycholic acid. The recommended recommendation is to start at 13 to 15 milligram per kilogram per day. And then we assess their response. Typically, that's at 12 months. If they're not getting better, or if they have inappropriate response, we start second-line therapy. This is the way to fail approach. The new paradigm with the availability of newer agents, now we can provide a more personalized care. So we can use therapies targeted to patient profiles, their liver tests, alkaline phosphatase, their fibrosis stage, their symptoms and risk factors. And the goal is to provide on-treatment response sooner rather than the traditional 12 months, so that we can tailor it to the individual needs. And it also helps us explain to the patients their risk of progression, their risk of cirrhosis or transplant, and help them not only reduce their injury, but achieve normalization in their biochemistry, so that we can resolve or prevent the ductopenia or bile duct injury, as well as fibrosis. And all that is hope that we can help them have a normal quality of life. So key takeaway, again, the first-line agent that's been available, approved since 1997, is the ursodeoxycholic acid. Second-line agent that's available now in the US, including OCA, that's approved in 2016, still available right now, and two fibrates for off-label use, and two new PPAR agonists, elafibranor and seladelpar, that's just approved this year. I would like to emphasize and highlight there's still many challenges in studying the chronic rare disease. It's very hard to do randomized control studies. Most of the studies suffer from small sample size, and it's very hard to have a solid, hard endpoint. That's why many studies depend on biochemical response as a surrogate marker. But increasingly, we are able to provide patient-reported quality of life in those studies to help us guide treatment selection for patients, and that hopefully will lead to a more personalized care for patients suffering from PBC. Thank you. That's all I have. Again, thank you, Dr. Gholam, for inviting me to give the presentation, and I welcome the discussion later. Thank you.
Thank you so much. That was a wonderful presentation, and running about 6 to 7 minutes late because we started a little late, but I hopefully will finish close to time. I do want to remind our audience that in the breakout session, which you are welcome to join at the end of this, this would be open only to providers who prescribe medication in the US. This would not be open to caregivers and patients. Let's move on to our very important part of the discussion. No discussion about any disease state, let alone PBC, would be complete without talking to stakeholders who experience the disease itself or care for persons with it. And so we are thrilled to have Carol Roberts, who's the president of PBCers, a PBC patient herself, and a patient advocate, to talk about these issues. So Carol, I'll start with something that Dr. Chiang raised at the very end of his, I think, very optimistic presentation about the future of PBC. I think Dian said that with the onset of a realistic expectation of normalization, there's probably new hope that the disease will slow down, and perhaps it is not inevitable for patients to develop end-stage liver disease or need advanced medical therapies like transplant. I guess my question for you is this something that the PBC community has a good understanding of, appreciation of, and is this a motivating factor for folks living with PBC?
Well, I would say that it's very motivating and very hopeful for those who fall into being diagnosed in this time frame when all this is available. But of course, a large portion of my membership of the organization has been diagnosed since 1997 and are getting to those late stage 4s. And so there's not a lot of motivation for them. They're still feeling, that and it's the same when I was diagnosed. I was diagnosed in 99, and they were saying, oh, this UDCA is wonderful and it's great. It's not going to help those of you who are in stage 4, which is where I was diagnosed. So it kept you from you were glad for others, but how does this help me? So it's kind of a torn opinion amongst the members right now, because they're trying to figure out how these new developments, if they will eventually be able to help them. They're too new to be given to patients that are in a precarious situation, but eventually some of them may be willing to try it just to possibly achieve a better outcome than they're currently headed for.
Great. Let's go back to you in 1999, or someone who is currently seeking a diagnosis, right? Somebody who perhaps is having fatigue, is having some itching that's out of the ordinary, has an elevated alk phos. I guess, can you take us through that journey of suspecting that something is wrong, to seeking a diagnosis, to actually being diagnosed? Is that hard? Is that the different if you live in Seattle versus rural Alabama? I guess all of these issues, right?
Well, I think the majority, you have to start with the fact that it's mostly a woman's disease. Women tend to put everybody else in front of themselves and, not recognize the symptoms that they should be recognizing. Eventually, when they do, it puts most of us back in the early days, at the stage where we were in later stages at diagnosis, because we didn't seek help soon enough. I think the abnormal liver function tests are being recognized sooner because they're being done for various things like health insurance. So they're popping up, and then you're dependent on your treating physicians to recognize what the next steps are after seeing them, and not writing them off and continuing. The first assumption is, of course, we're drinking in the afternoons when we're home sitting with our children. We're hopefully fighting that one, but believe it or not, it still gets brought up an awful lot in physicians' office and in ERs. We've made a lot of progress as far as fighting that stigma, but there's still some that goes from there. So, it's getting a quicker diagnosis than it used to. Right now, I think actually the men are kind of having a worse time, because they're definitely not looking for it in men. And I can say we have a private support group that is for patients only. And during the days when COVID stopped being an issue when going to doctor's offices, I was having at least one male a week want to join the group. And that's a big difference from what we had before. I realize there are some, it was mentioned today that, they feel the male population is increasing, but I think it's been a big increase.
Wow, that's really not something I had appreciated. So I guess if you poll the PBCers, right, the folks who are very invested in this, from the time when they were diagnosed to the time they actually sought hepatology care, is that a difficult process? So now I have a diagnosis of PBC. I don't live in Salt Lake or Cleveland or a big city necessarily. Maybe a gastroenterologist diagnosed me, or maybe a very astute internist diagnosed me. How do I transition to where I get competent and specialized care?
It is difficult for the areas outside of the bigger cities. Some of them would have to travel, hundreds of miles to see a hepatologist. I don't live in that small of a city, but the only hepatologists in my city are associated with the transplant team, which I'm fortunate to have right here in my home. But I find that you can receive good enough care for the majority of patients from a GI who's invested in his practice. He may not have been overly familiar with PBC, but my theory is that if you have a patient that is diagnosed with something, you either catch yourself up on everything you need to know, or admit that you can't handle it and find them a better solution for treatment.
How about medication access? Are you seeing among the PBCers membership challenges with people accessing either first-line treatment like UDCA or second-line treatments like OCA, elafibranor, and seladelpar? Has that been a challenge for the folks who need these drugs?
First-line treatment has gone up and down over the years that I've taken the product. There were times that it became, it wasn't really a problem when it was brand name. When it went generic, then we started finding more competition and the price went up.
Yep.
And in some places it still can be costly. There are a few nonprofits that will help in assistance with UDCA. There isn't any pharma supported because it's generic now, so nobody has anything to do with it. The newer medicines all have established patient assistance that is available. I know a lot about the financial assistance that was set up to go with Ocaliva. I'm still learning about the two new and how the assistance actually works and how easily it is accessible for those. There were quite a few who were able to take OCA with virtually no copay, and that was very helpful. I'm not hearing that yet from the two medicines, and it's something I need to investigate and find out more for my membership on how that's going to actually work.
Okay, I guess the last question, and then we'll take some from the audience. One particular comment you made about the irony that when UDCA became generic, suddenly we and our patients, I think Terry and Dian both nodded, and I fully agree with them. Unfortunately, the dirty secret of UDCA is that there is sort of almost a monopoly of generics on the drug, and in fact, access to the drug became so much more difficult after it became generic, which is exactly the opposite of how it should happen, and it's a shame.
Well, another comment on that is the fact that, of course, it's unable to determine, but about the time it became generic was the same amount of time that like Facebook came about. I never remember hearing people talk about as many side effects when it was brand name as when it went generic. But
That's interesting. Really? Oh, really?
But it could be that Facebook allowed that platform to occur, which we didn't have as easy a way to complain before that. So, but it really does seem that suddenly there's a lot more things that are said, oh, well, if you take this, this is what's going to happen. And the first group of us, maybe we were just so grateful to have a treatment that we didn't notice all these little nitpicky things that, people will say are bothering them from taking it.
I have never heard that, but Terry, do you notice that generic UDCA gives your patients more side effects? That's fascinating too.
No, I was unaware of that as well. So, I mean, thank you, Carol, for your great insight. This has been a very enlightening part of today's discussion.
Dian, do your generic UDCA patients have more side effects? That's incredibly fascinating to me.
Yeah, that's new information to me as well. I'm glad that you shared that, Carol. I feel some of the patients in my experience, when they switch from one to the other, from the brand name to the generic, initially they may complain that they notice more side effects. But for those patients who start out on the generic, I'm not finding more side effect as a result of that. So that's been my experience.
Well, I found in the generics that it makes a difference who the manufacturer is for different patients. When people first started saying, it was giving me this issue, and I would just kind of, listen to them. And then my pharmacist changed manufacturers, and I experienced what it was like to spend the afternoon in the bathroom after taking one manufacturer's product as opposed to another, because of the filters that were in it. So I always have to check when I order mine that they make sure it's not two of the particular manufacturers, because they just do not, I don't tolerate them at all.
And in fact, corroborating what you just said, we have a comment from a patient who is listening, Maria, who says, as a patient, this is true with the difference between generic and brand. There seems to be different stabilizers, fillers or preservatives, and these seem to give you more diarrhea, which is exactly what you're saying, Carol. So not related to the patient journey, but when Bill Carey asks a question, we have to ask it and answer it. We cannot leave it. We cannot leave it up in the air. That's the prerogative of being Bill Carey. So tell me why budesonide is not part of this discussion. He's referencing the J Hepatology paper from 2020, which I would submit to you is a bit of an outlier. But Dian, why don't you take this one real quick? Yeah.
Sure. I think there has been studies looking at immunosuppression in PBC treatment, and budesonide being one fine example. We know that PBC is an autoimmune disease, and that in theory, immunosuppression should work. However, many patients, when they present, their disease has progressed to a point that cholestasis is the main driving force of their disease progression, as well as the progression of their fibrosis or complications. So therefore, in studies later on, oftentimes we're not seeing significant improvement in using immunosuppression therapy, including budesonide. But I do think there is a small subset of patients who would benefit from immunosuppression therapy. How to define those patients and decide when to use and how to use it is a challenge.
So let's end on this note, Carol. If you and PBCers had a wish list, and this not necessarily applies only to policymakers, it applies to us, the doctors and providers too. What would that wish list be in order of most priority to less priority? Let's put it this way.
Well, the number one wish on our list is that we finally can settle on a cause and most likely a cure. But that is a ways out, takes time. My number two would be to increase the awareness of the disease with the public and with healthcare providers. There are still far too many that aren't aware, and patients don't get proper care because of that, or delayed proper care. And my third and last one would be that patients are given information on their diagnosis on the disease and on the support available to them outside of the doctor's office. I could go on for hours, but those were the top three.
No, those. I guess the other very inherent to PBC and the specifics of PBC, I think, is the importance of listening to patients talk about their symptoms, listening to them talk about the side effects of medications, right? So tonight we learned something that I honestly did not appreciate, and I don't know, perhaps we should do a better job taking the time and listening to our patients, and that might give them a better outcome.
Well, one of the things that I try to stress to my membership is that, yes, we want the doctor to listen, but we also need to be cognizant of the time limits and to make sure you're prepared for your appointments. If possible, ask some questions or send the questions in through a patient portal ahead of time. But your doctor cannot answer 14 different questions. You need to kind of summarize what's the best and make sure you share within the limits that, and be respectful of their time as well as them being respectful of yours.
Fantastic. All right. Well, I'd like to thank you, Carol, and certainly Drs. Terry Box and Dian Chiang for absolutely fantastic. And this is a real tour de force to cover all this ground in an hour and 5 minutes. Not easy to do. So thank you so much for doing this. I'll remind the folks who are still on with us that there is a breakout room. This is only available to providers, not to patients or caregivers, just based on prevailing laws, I guess. You're welcome to join our supporters and interact with them in a virtual booth fashion. Thank you so much to everyone.